So today we're going to focus in our presentation on NHS health checks. So we're going to look at why uptake varies so much and what the evidence tells us about improving completion rates and impact through smarter targeting and better communication. So within the presentation as well, we're going to touch on some insights that we've gathered ourselves within Redmoor from projects we've worked on to improve health check uptake. So we just start with some housekeeping and introductions. So I'm Matt Sweeney from Redmoor Health. As our Product and Operations Director, I'm joined today by Dylan Sykes, our Commercial Director for Digital Transformation and Partnerships. I'm going to talk through the first half of the presentation and then going to hand over to Dylan. So in terms of housekeeping then, we've put you on mute for the time being, but we'll be accepting questions at the end. We'll take you off mute and we can have more of a conversation. But if you've got questions throughout, please just use the chat or the Q&A section and we'll sort of keep tabs of it and go through them at the end. We are recording the session today and we will be sending out over email a link to the slides themselves and also recording. We're also going to be putting the slides up on our D&T Network forum. So this is a free forum community for anyone involved in sort of digital transformation across sort of primary care and other healthcare settings, and provides the opportunity for you to view assets and templates that we put together from these slides and also ask any follow-on questions. So just to start explaining a bit about Redmoor for those who don't know, so we work with over 1,700 practices across England. We work both at practice level, but also with PCNs, ICBs and public health teams. And our work spans digital transformation and patient communications. So on the digital transformation side, we will help primary organisations like improve their workforce optimization, improve how they use technology to improve how they work, whether it's telephony, online consultations, using NHS apps to the maximum, and things like that. And we also manage over 850 social media pages for GP practices. So they'll trust us to manage their Facebook pages. So we've done a lot of work around patient comms. Because we work with practices sort of day to day, we've got really clear insights into how different approaches to communication affect patient behaviour. You know, what makes booking easier and what actually improves engagement with prevention programmes like health checks. So I think that frontline perspective is really important in terms of actually moving the needle, in terms of making health checks effective and used. So we start by sort of looking at what is the value of health checks. So we did a bit of research on sort of department health modelling and public health modelling around this. On the health outcome side, when health checks are rolled out, they're believed to help to avoid 650 premature deaths each year. 1,600 heart attacks and strokes can be prevented annually, and also 20,000 earlier detections of diabetes and kidney disease each year. On the cost effectiveness side, there's a really compelling argument for increased investment into health checks. So NICE use this methodology of quality adjusted life year. So they use this when they're determining whether they're going to green light medication to be funded under the NHS. And the typical threshold is around between £20,000 and £30,000. So if it costs that much to provide an extra quality adjusted life, that's usually considered a good enough investment to fund. Health checks, the modelling shows, have a quality adjusted life year of £3,000. So 10 times more cost effective than that upper threshold that NICE will usually use to greenlight medications. So you can see it's a really compelling cost benefit analysis there. On the economic side, across the 20-year sort of lifespan for society, it's believed that £1 invested into health checks produces a £2.93 return, so almost 3 to 1. And that's driven by, first of all, those health gains that I mentioned around the QALY, but also the avoided NHS and social care costs that come with earlier prevention measures, and also the wider economic benefits in the workforce of people are able to continue in work rather than getting diagnosed and being on treatments and missing work days. So I think the value of health checks is all the research that's gone into it over the last few years is pretty compelling. Now, if we look at variation across ICBs, so this is looking at standardised rate per 100,000 patients. And you can see here the variation between all the ICBs across the country, and the ones in red are sort of the lower 25% quartile and the greens are the highest. And what's interesting here is there's almost like a 3-to-1 gap between those that are most effective at health check completions versus the lowest. And when you actually look into what the areas are, the reason for this disparity is not down to like the patient demographics. You may think, oh, well, some areas it's just going to be more difficult to get them to do health checks. But when you actually look at the makeup of those ICBs, that's not telling that story. It actually is hinting that the variation is much more down to the systems and processes and delivery models that are being used to invite, bring in, and complete health checks. So we see the challenge as sort of three overlapping challenges here. So you've got the wide and avoidable variation. And that variation is not at the ICB, it's not just at the ICB level. There's also massive variability within practices, within local areas as well. And what we found in the research is that the highest risk groups are often those that remain the most underengaged. So if you're seeing areas with lower health check update, there's almost a double whammy hit because the lower variation is likely coming from those harder to reach patients who are more likely to benefit from the health check and get new diagnoses. And that preventable illness continues to drive cost and pressure into the system and through being undiagnosed. And so this problem largely sits with communication gaps. So I think a lack of consistent and coordinated comms can be a major driver of uptake in health checks that we'll talk about later in this presentation. And fragmented or low visibility messaging leads to those inconsistent results. And the central sort of challenge that feeds from these is that there's a massive operational pressure in primary care. So the bulk of the responsibility for identification and delivery and follow-up for the health checks is sitting with practices who are under tremendous pressure generally with supply to demand gaps. They've also got other priorities like QOF. And so focusing on prioritizing health checks can sometimes fall under the cracks, and not investing in it enough can make a lot of differences in terms of uptake. So we look at sort of responsibilities for health checks. So councils have obviously got responsibility for the commissioning and funding the health checks and setting that prevention strategy. But ICBs, particularly with the new remit for them, are being given a big push to focus on prevention. And they've got that responsibility to be that conduit with the primary care to provide data insight, support primary care relationships, and ensure alignment of health checks with wider prevention work that they're dealing with. And then practices sit at the coal face. They're sort of at the sharp end of the bargain, where they've got to identify the eligible patients, they've got to manage the invites and deliver the health checks. And I think this slide really sort of illustrates how much does sit with the practice and how much responsibility they've got. And where you don't quite hit the mark in terms of that responsibility, it can really vary the uptake rates. So first of all, they've got to identify eligible patients, communicate the risks, deliver the health checks, and they've got to manage the follow-up. But if the identification is blunt, if the messaging is unclear, if the booking routes are difficult, uptake's going to drop quickly. And conversely, small improvements at each step can compound into much better outcomes. And then the other side as well, in terms of the actual follow-up, once a patient has received a diagnosis or received a health check, or they're being followed up effectively, that's where, again, there can be massive variation. So, for instance, we saw a study from last year from Department of Health that showed that only 5% of patients who are identified as smokers in health checks were actually being referred into local available stop smoking services within the council. So there's a bit of disjointedness there sometimes between what council services are available for prevention services and what patients are being referred to by practices, and that's often due to lack of awareness and visibility. So this is some research that was done, again, I think it was from Public Health England, looking at the methods, the practices we're using to identify patients for health checks. So I mentioned earlier that the way that patients are identified can make a massive difference. And you can see here it's quite unsophisticated. So the largest chunk, the largest sort of method of communicating to patients is just based on age and year of birth and birthday rather than risk factors. You've also got the alphabetical, never previously had a check. So segmentation as a general policy within primary care, it's not sophisticated as we want it to be. So we've looked into different research that's been done into health check uptake, and we did this before we managed the project ourselves. And there's a really interesting study from Solutions Research that did in 2022. that they looked at, they basically defined patients into different cohorts, analysed why they didn't do health checks, what the take-up rate was, and then defined new pathways to see whether they can move the needle. And what they found is that, first of all, only 38% of adults are actually aware of health checks, and awareness is lowest in the highest risk groups. So that's it's quite a surprising statistic for us when we were reading it. And I think it shows the value of bearing that in mind when you're sending the messaging. If you assume knowledge of a health check when you're sending out communications, but someone isn't aware of it, it can cause confusion, anxiety, they're not sure what they need to do, and that can affect the take-up rates. And as part of it, they were able to define 4 segments, 4 personas of patients: struggling, hesitant, disempowered, dismissive, curious, concerned, activate to listen, that hold the highest burden of CVD risk factors, but who need to be tackled in different ways if they're going to actually be brought in effectively for the health check. But some of the broad lessons around those highest unmet needs was they prefer GP branded messaging, simple non-judgmental language, reassurance about what the check involves, in-person or phone support rather than online journeys. And they also need to not just have a digital only approach. So often provide, like, defining a cohort that's particularly digitally excluded and having an alternate strategy for them, whether it's calling the patients up directly, will often serve you a much better way of reaching those patients. And so I think that the key takeaway from this slide is a one-size-fits-all approach to outreach just doesn't cut the mustard if you really want to have an effective communications route for health checks. So this was another study that was done in Southwark, a randomized control trial across 28 practices that reviewed doing different message types based on behavioural cohorts to invite patients into health checks. So this is just based on messaging and sending different types of messaging, and they were able to increase uptake from 18% to 30%. So we're not just talking about small edge case differences in uptake based on changing the messages, not like a 1 or 2%, almost double from 18 to 30% uptake in the health checks just through segmenting patients and changing the messaging. And then another study from Public Health England, this is around opportunistic presentation of health checks within touch points that practices have with patients and how that affects health check uptake. So staff used any patient interaction, whether it's in person, by phone, during another appointment, as a chance to book that health check. And what they found is they saw a 25% increase in completed health checks during the intervention. So this can be particularly powerful when practice staff are really encouraged with a process and methodology to make every contact count. And where a patient presents that they think would benefit from a health check, they are being referred to there and then. And that can produce really good results. So it's not just about the messaging, it's about having an overall sort of communication strategy that includes in-person strategies. Right, so I'm going to pass it over to Dylan, who's going to cover the next part of the presentation.
Thanks, Matt. Yeah, just let me share my screen, guys, 1 second. Hopefully the tech doesn't fail me. Great, you should all be able to see that now, hopefully. So yeah, thanks, Matt. Just a quick introduction to myself. So I'm Dylan, Commercial Director at Redmoor Health, and I was heavily involved in working with the Director of Public Health at Lancashire County Council, where we designed and led a 12-week pilot on improving uptake on health checks. I'll touch on today more about the practical side of this work and the things that help people engage with health checks and make prevention feel easier for practices and residents. I'll also walk you through what we see across the country, the things that tend to make the biggest difference as well. I'll touch on that programme in Lancashire around the health checks. We'll look at some of the simple do's and don'ts, something you can actually take away from today as well and talk to your teams about and you can use locally. And we'll look at about how this model can actually apply to the wider prevention agenda as we come to planning for 26-27. So when we look at uptake, it tends to come down to 3 simple things. It's who we reach, how we speak to them, and how easy we make it for them to take up that offer. So first things are really that identification. This is when practices have the right searches, so that's your clinical searches using either EMIS or System 1 mainly, and can clearly see who's at higher risk or who hasn't responded yet, it becomes much easier to focus your effort where it's needed most. Yeah. So it's not about more invites, it's about making those invites you send more useful. And I'll touch on some of the numbers shortly on some of the slides and give you some examples to demonstrate that it's not necessarily about the number of invites you send out as well. In terms of messaging, the way the invitation is phrased, your tone, and the sense of reassurance behind it all really do matter. We see better engagement when the message feels personal, it's clear, and it's from a trusted source. So they recognise it's come from the GP surgery. And different groups respond to different channels, we find that, and you probably know that yourselves. So supporting practices with a mix of options really has helped. And again, we'll dig into some of those different options shortly. And finally, even when we get the first two right, things can fall away if booking journey is complicated or unpredictable. So keep your booking rules simple. And I probably mentioned this a couple of times because I think it really is important. And make sure that you've got that appointment availability to make the whole process smoother for everyone from reception and patients as well. So it's about understanding these small practical things that'll help more people say yes to a health check, and that's hopefully what we're going to touch on next. In terms of what a typical patient outreach looks like, this slide is just a reflection, I think, of what a lot of us might see in places. And on one of the earlier slides, Matt mentioned about 45% of practices still relied on age and year of birth for sending out their invites. We know that most areas do send invites out and they follow the practice or local process that's being in place, but it can be quite basic, and that's not a reflection on the practice. It often needs to be done quickly. Practices firefight a lot. They've got the acute on the day demand that they've got to sort out as well. And this often doesn't support the groups then that need the most encouragement. So a lot of invites still go out using that month of birth with no sense of the higher risk or who hasn't responded before. What we've seen from text messages as well can be quite generic when we've reviewed them. There's often no direct booking link, so the patient has to phone the practice, and that's where they drop away. You get a nice text message, oh yeah, that looks good. Oh, I've got a phone, I'm busy, I'm on lunch, I haven't got time, those types of things, and then you never follow through with it. And then when it comes to some of the pitfalls, follow-ups, because GP practices are busy, there's usually limited follow-up for people that don't respond the first time. I'm probably one of those people. And there's very little communication then happening outside of that text or the letter you've sent to the patient. So practices do work and they work hard, but the return for them can be modest just because the system around them doesn't make it any easier. So this isn't about criticising any of the practices, it's just the reality that we find of how things have traditionally been set up. On flip side of coin, we have got proactive patient outreach and what good looks like. So this slide will show the contrast really with practices and areas where uptake really does start to move, and this is what we've seen. For me, the big difference with this is it's more intentional rather than just reactive. So they do target the groups that actually benefit most. So this includes those higher risk patients or those who haven't maybe engaged before. When you look at this kind of response process compared to the one we just looked at, it's around 1 in 3 versus 1 in 20 that are identified with a new risk, which is CVD and diabetes. So you are actually targeting the right people that are at risk rather than just sending out to a bigger group of people that maybe not at risk. So it's worth looking at. Also designing the right message. Adapt your message so it feels clear, relevant, and it's reassuring, especially for people that might feel nervous or unsure. For those that don't necessarily engage with you all the time, but they've now fallen into that eligibility zone, if you like, they might not want to come in and find there's something wrong with them necessarily. So that reassurance, that message really does help. And it's that trusted GP practice voice that makes a really big difference for them as well. And again, make it easy to act. The easier the action is, the simpler the booking links. Make sure you've got your available appointment slots and the rotas on there. Don't be asking patients to book ahead if they're not there, because they'll get really frustrated then when they go to the booking part of the process. And if they do cancel, make sure there's an easy way for them to rebook if needed. Just think about that. So when you're talking and working with your practices, how do practices get back into the system if they dropped out on the first run as well? And then reinforcing that message as well, make it gentle, visible ways. I'll come on to talk about your social media pages, your website information as well. I think over the years, there's lots of varied information that goes on practice websites. Some aren't great, some are. It's worth taking a look at your digital front door as an area or a region. Is it set up for patients to understand what services are available and what work needs to be done around that? Is it also aligned to the local authority and NHS in terms of the digital front door and where patients can access help and advice? Not everybody consumes information online, we know that, so it's really important that your waiting room screens reflect what's online. You've also got your notice boards in reception as well that are kept up to date with information around health checks. And lastly, there's the opportunistic offer really during any routine contact, so from reception, healthcare assistants to GPs. How do you engage those people to make sure that they all know what an NHS health check is, who's eligible, and how they book onto the system as well? A lot of times in the practice, they might just say, oh, it's nothing to do with me, I don't know how that works. So they're missing an opportunity when they're having a touch point with a patient, and it could be from a telephone call, a text message to face-to-face. So it really is important. So when all this works together, we see a noticeable lift in completions, and more importantly, we see more early diagnosis. They are small changes, but put them all together, they do add up and have a nice impact as well. So these are insights from Redmoor's recent work with Lancashire County Council. It's a really helpful example of this because it shows what can be achieved in just 12 weeks with a bit of focus and support. So I was involved with Director of Public Health over the summer, looking at how we can engage primary care better and help them support the process of delivering and getting better uptake as well. It were like a fourfold objectives that we wanted to achieve really. So firstly, we wanted to look at increasing health check updates. So just raise the completion rate of NHS health checks over a 3-month period. Wanted to reduce inequalities, so narrow that gap between uptake of the deprived and less deprived patients. Improve early detection, so identify and refer patients at elevated cardiovascular, diabetes risk, etc., and make sure we caught them earlier and facilitated that early intervention. And then finally, we wanted to demonstrate scalability and develop an evidence-based model that can be rolled out to other areas and inform future programs, not just around health checks as well. We had 5 practices and all took part. We did think, oh, will everybody come forward and want to be a part of this? So in partnership with the council, we agreed we'd give them actually £500 for taking part. We paid £250 at the beginning, £250 at the end. And we had about 37 practices come forward. So we had to choose which practices we wanted to take on board. The good news is that they saw around a 60% increase in completed checks, and that's compared to baseline data. Now, we are currently just in the middle of pulling all this together, so look out January, February time for more information and hopefully another webinar for myself and Matt on that. So we didn't give them any more clinicians or capacity, so they were only supported with better targeting, clearer messaging and tailored text messaging and avatar video links, which I'll come and show you. And we helped set up a more consistent booking route. So it was that wraparound support that really helped them. The practices still did the health checks as normal, nothing changed there. We just like to think we helped create the conditions that allow more people to say yes. I think it also showed the value of partnership working. We had the local public health team, we had practices and our team. We were all aligned around the same goal, and we all got to see a view from each other's, if you like, mountaintop of what it meant to them. And that were really quite important as part of this programme. It's been a really powerful combination for those involved as well. So this slide really is about recognising what we saw and that people now take information in very different ways. We know some respond to that direct text messaging. It feels personal, they like that, and it's easy for them to do. Others like to take things in visually, so you've got your video, your graphics or your posters. As you can see on right-hand side here, we've got two very different posters and approaches for segments of the practice population that they wanted to appeal to. So on the left-hand side, you've got your health MOT is due. They wanted to appeal to the middle-aged, if you like, manual worker. The work maybe 6-7 days a week at times, often work for themselves, don't put themselves forward or first when it comes to healthcare. And on the right hand side there, you've got a practice population where they wanted to appeal more to the female population within Asian communities as well and try and appeal to those people. So it also matters visually what you're sending out. We do know as well that a lot of people just scroll Facebook, Instagram on an evening. People in my family do it exactly the same. And GP practice social media pages really do fit into this because they're trusted and they're local. It's like a familiar voice in the community, and they're often reaching people that don't always check their invites, etc. So it's about meeting residents where they actually are rather than expecting one single channel to do all that heavy lifting for us. At Redmoor, we've managed over 700 social media accounts for GP practices, so we know the value of trusted content and the impact that right message can actually make. And sometimes people might only absorb information when they're in the practice or when it's explained to them, so it's really important that you're repeating that message in person as well. So this follows on nicely from the last slide. If people consume content in different ways, one of the most effective things we actually did was amplify that voice that they already trust. So be it a GP, nurse, somebody from the practice team. So we support practices to create short, simple AI avatar videos. Really good fun, actually, if you like that kind of thing. We weren't short of volunteers from GPs that wanted their own avatar, but what it allowed them to do was be able to put out multiple messages in different languages and formats, and you could use that same clinician or a reception person as well. They're really quite powerful in terms of you can send them out in messages to patients on the phone where they can open them up and they can see and hear the GP. And the different languages really do help. So obviously you're not always going to have the clinicians that can speak lots of different languages. With this, you can actually put in the translation and it'll come out to that patient speaking maybe Polish, Tamil, etc. in your community. What it has done is removed a lot of anxiety around what the health check involves. It's not about leading with a tech or being flashy. It's giving the practices that extra way just to reach communities who may not respond to texts or written invites. So again, if you want to look at avatars, do get in touch. They're quite a nice way of reaching out to your patients. So now, do's and don'ts for you. Again, these are just reminders that the small details in messaging really do matter. We have done a lot of work on patient messaging and that digital front door with practices over the last couple of years. And how the message lands is really important to what happens next. So again, I'll reinforce it's clear wording, reassurance, a simple call to action, and ideally with a booking link. That tends to get best response. To give you an example, for myself, last week, I went into the surgery a couple of weeks ago. They followed up with a couple of messages to myself. One was to ask me to book some blood tests, and one was to ask me to come in and talk to a clinician face to face. One of them had a booking link included. One of the messages just said, give us a call. I've actioned one of them, and you can guess which one it is. The other one, I haven't actioned yet because I ain't had time. It's something else I've got to do on top of reading the message as well. So it's really important to think about how you want patients to respond to you as well. So it's not about sending more messages and invites out. That can be a turn off. It's about making each message easy to act on. And we've seen this in action as well. And hopefully that'll come out in the evaluation. So this slide just brings together what we typically see working well in practices, just to give you some idea. We've already touched on how different groups respond to different approaches. So it's about matching that message and the channel to the right person. Again, we know some people are fine with SMSs and booking links, while others do need a quick conversation at reception or a bit of reassurance from someone they trust. How do you make this happen? Have you had those discussions locally? Yeah, you know your populations from local authorities and NHS better than anyone. Do you need to bring in maybe somebody from the community, the voluntary sector? Can they actually go out there and help people understand what they are as well? So those conversations, this isn't just about a digital program. It's about making sure those needs are met for all people, either online or offline as well. think about your screens, those posters or a gentle prompt during another appointment as well that we've always touched on. They really are quite powerful. So the framing of the message really does matter. Simple, clear wording tends to work best. Different groups respond to different prompts. So think about whether that's using the things like, is it quick and easy? Is it free and simple? Or is it worthwhile? Who would you use those phrases with just to have the biggest impact? So this is an important point, why the budget for comms and practice support. Well, it's not just because I am a commercial director, but it is important to have that budget because a lot of the variation in uptake comes down to the support around the practices, not the population itself. And I think Matt's chart demonstrated some of that itself with the variation that we saw. So having a dedicated budget for comms and practice support really does help create that consistency. It supports your delivery arm with better outreach, clearer messaging, smoother booking routes. And we know those are the things that usually drive biggest improvements. It can actually make you the hero in your whole prevention story just by including this in your service. Yeah. So there's also a wider opportunity, I think, as well, to be honest with you. So most ICSs have got aligned budgets for prevention and public health targets. So it might make sense for our local authorities, ICBs, to explore co-funding or aligning efforts. So we're all actually working towards that same outcome rather than running separate streams of work. Only Monday this week, I did speak to a director of public health and we had the ICB lead, and they were talking together about our joint prevention programme would look for next year. So it's good to see that some of those conversations are actually taking place. And I did touch on earlier how this could support wider prevention. So health checks don't sit in isolation, we all know that. The same channels and approaches support other parts of the prevention agenda too. So you'll all be probably identifying your priorities and prevention strategies for going forward, such as stop smoking, weight management, wellbeing programs, alcohol support. And many of the residents we're trying to reach just overlap across these areas into your prevention streams. So improving outreach at practice level isn't just about the health checks, it's about strengthening the whole prevention arm as a whole. So if it can help us build a more consistent and accessible pathway, I think that works better across the whole system and having that one approach. That's it, guys. I'll finish by saying that if any of you want to explore how this approach could support your population, happy to talk that through with you. We know every area is different, but the principles tend to hold the same. Clearer targeting, better communication, and easier access usually leads to more completed health checks and prevention. So that's it, folks. Thanks for listening.